the stage. And we also like to introduce our first of the day, second distinguished moderator, Dr. Mary Beth Hughes. I will give us her presentation now.
Thank you. Thank you, everyone. Thanks to the AAS for the privilege of the podium. It is truly an honor always to be here among friends and colleagues. Today, I was asked to talk about what's new in neuroendocrine tumors, and I've taken a little bit of privilege of the podium, so please forgive me. For the folks in the room that don't do neuroendocrine tumors, it's a mixture of what you need to know and mixed with what's new. So if I could have my slides, please. Maybe. Wonderful. So just a quick brief outline of what I'm going to talk to you in just a few minutes is I just want to briefly touch on the incidence of neuroendocrine tumors and then some diagnostic updates, and then following that, what I think you have to know about surgery, and this is stuff that we should already know, but just to highlight a couple landmark studies, and then talk a tiny bit about the translational science and some exciting trials. And for that, I'll mostly be talking about pancreatic neuroendocrine tumors. So first, just if you look at this slide for the incidence, that blue line on top, this is SEER data. The blue line is the incidence of cancer over time. If you look at the red, that is neuroendocrine tumor incidence over time, which is just exponentially continuing to go. If you look at more SEER data, this is broken down by disease site. And what you learn is that 58% of neuroendocrine tumors are in the GI tract, and that's in decreasing incidence, small intestine, rectum, pancreas, stomach, appendix. But again, all the lines trending north. So when you look at diagnostics, I want to talk about two different modalities. One, if you'll give me some grace here, just talk about a published paper that we just published a few months ago surrounding neuroendocrine tumors, small intestine neuroendocrine tumors using capsule endoscopy. And the other is looking at PET imaging, because we know about gallium dotatate, but there is a whole bunch coming down the pike that I'll just very briefly mention. So for us, we did a video capsule endoscopy study in familial neuroendocrine small intestine patients. This is just a picture of what a pill cam looks like. In case you haven't seen it, it's pretty small. People can swallow it, or they can throw it down in an EGD to get it to tumble through the GI tract. There's 6 little cameras in that head. They take pictures as it tumbles down. All you have to do is do a clear liquid diet so they can get adequate pictures. On the next slide, I'm going to go to it in a second, but they're going to hit a video. So I want you to pay attention to the video and look for the little yellow bright light bulbs, and those are the small intestine neuroendocrine tumors. So it's just a nice example of why this is so good. And so see those guys just popping off, and you'll see some still picture on the right. And so what's nice about this is it can pick up tumors, and it's not very subtle. And so just to go through what we found in 175 asymptomatic patients that had at least 2 family members with confirmed neuroendocrine tumors, they got both fluorodopa PET and a capsule endoscopy. And any positive either imaging study or capsule went to surgery. And so I know that the PI had a lot of chest pain early on when we were going to surgery with just capsule positivity. But it turns out that of the 32 patients that had confirmed neuroendocrine tumors, 81% had multiple tumors, and the capsule detected 28 of those 32 patients. So it had 87% specificity and a 0.5% sensitivity. So on average, we found 7 tumors in these patients, and they were on average size 5 millimeters. So it's quite sensitive. When we looked at that compared to fluorodopa PET, then that had similar sensitivity versus surgery. And so it's really nice that we can finally confirm that capsule endoscopy is very useful in finding these occult tumors. And then when you look at PET scans, so everybody knows about about gallium dotatate PET. So that's just a picture of one of our patients, and we take advantage of the serotonin 2 receptor, which is that green molecule going across the membrane. You can put different links, whether it's dotatate or other vectors, and so that's kind of where people are going in the PET space. And so when there's a couple of different protocols that are out there. First, they're looking at the Nadaga and Cedrin 4 PET. And that is actually very interesting because it came out of diabetes literature, and it shows beta cells, and it's very sensitive for insulin-producing cells. And so it turns out that they found, incidentally, that you can isolate insulinomas very nicely with this. So when you have that trouble localizing insulinoma, that's been very helpful. And then again, last year in the Journal of Nuclear Medicine, they did a prospective trial using gallium dotatate PET against the Nadaga JR11. Don't ask me about these linkers, because I'm not entirely an expert in nuclear medicine. But what they did is they ran them through the PET one day with one linker, and they ran them through the PET the next day with the next linker. And we all think gallium dotatate PET is so good, because it's such an advance compared to what we had in the past. But it turns out that this new JR11 business is so much better. So it had 91% sensitivity compared to 77% for our gallium dotatate PET. So it's interesting that these things are kind of coming down the pike. And so they looked at liver lesions. They had 673 liver lesions compared to 584 with the conventional gallium dotatate. So look out for that coming. These aren't quite prime time in the US, but they're all on the way. And then finally, there's a trial that they did in Copenhagen, which actually looks at NODA E105, and that actually looks for UPAR. And so UPAR has been indicated in malignancy, in multiple different malignancies. So it's going to be fascinating to see what that shows when that results. So there's exciting things on the diagnostic side of things. And so this is where I have to take a step back and tell you that I had to take the liberty of talking about these two slides because I think everybody in this room needs to know about these trials. The first is this one that came out of Chicago, and this is a practice-changing trial. And so I think it's not super new, but if you don't know about this, you should. And the nice thing is it allowed us to get our medical oncologists and our endocrinologists to send these patients back when appropriate to help them. So if you look at this slide, and it's going to be very difficult for me to read from 4 miles away, but the very green, as I recall from my memory, this is when people have metastatic disease and liver metastasis in GEP-NETs. The green on the left Kaplan-Meier curve is when you do surgery for liver metastasis and the primary. And so you can see that green line looks great. Everybody wants to be on the green line. If you just take out the primary, that is the yellow line. So still very good results. The blue scattered line that you can barely see is if you just deal with the liver metastasis, and the red line is no surgery at all. So this is the first time where they showed a survival advantage with taking out the primary, and it's shown very clearly. The next line over, that Kaplan-Meier curve, is for liver metastasis and extrahepatic disease. So the green is if you deal with both. I think the next line down is if you just do the liver, and the bottom is no surgery at all. And so it just shows in widespread metastatic disease in these patient populations, surgery is still the way to go. And I'd be remiss if I did not give credit to these gentlemen who are no strangers to this community, who basically were the fathers of being more aggressive in metastatic disease because it moves the needle and it extends life of these patients. Because still, surgery is the only cure for these patients, and it is still the tool that we have that has the best objective response rate by far in this disease process. And so on the left, you can see the liver-specific survival on the bottom. On the right, you can see the difference between debulking 70% or greater or 70 or less than 70% in Dr. Howe's paper. And so these are still important things. So very quickly, to talk about some translational science in pancreatic neuroendocrine tumors. It's been an exponential growth of seeing these because they're found incidentally on CT scans. The controversy still exists about taking them out. I say when in doubt, cut it out. It cannot metastasize from pathology, but that's just me. But we have widely available genomic data for these patients. And so there's lots of these mutations that are being described, driver mutations in MEN, DAX, ADARAX, mTOR pathways, which we know PTEN, TSC1 and 2, all of these have been described by our members in the past, and they're all implicated in disease progression and poor outcomes. And then we have higher than expected germline mutations in some of these sporadic patients. And so that we're starting to look at the chromatin remodeling in these tumors. And so we're starting to use new agents. So ASTX727 is a oral epigenetic modifier. So it's got decitabine, and it has a cetazizuride, excuse me. It has a new brand name. Don't ask me how to say that, but it just got FDA approved for myelodysplastic syndrome, so now it's got a brand name. But in any event, they're starting to use these in clinical trials because decitabine is a hypomethylator, and they're starting to work on the epigenetics of these tumors. So the promising targetable mutations are also being described in PNETs, but the preliminary studies aren't fabulous because they're looking at objective response rates. So I don't know that we're looking at the right endpoints in these trials. And then, of course, just a few other ones to kind of keep your eyes on. Very interested in MSK has a phase 1 with lutetium dotaebtate, which is a radiolabeled analog of somatostatin receptor, so that'll be fascinating to see what that does. The COMPOSE trial, which is an ongoing multi-institutional trial, 36 sites, 38 sites, says the slide. But anyway, so a lot of institutions here are participating in that, and then a phase 2 that just finished up with some immunotherapy. So a lot going on in this space. I think my final take-home messages for the group are please continue the good fight. Surgery is still by far the best tool we have in this disease. Surgeon scientists are absolutely critical to this. I think the issues are surrounding mentorship and funding. And so I think we have to make sure we concentrate on that, because the only way we're going to move forward is with that and collaborative science, because this is not a super common phenomenon, although the incidence is rising, and therefore we have to collaborate to move things forward in the space. And thank you very much for your time and attention.
Thank you, Dr. Hughes, for that fantastic update. Let's move directly to our first paper. I'd like to call Benjamin Greenspun up to the podium to present the paper entitled DAX Associated with Aggressive Pancreatic Neuroendocrine Tumor Behavior After R0 Resection on behalf of his colleagues at the Weill Cornell Medical Center.
Hey, good morning, everyone. All right, thank you for that introduction and for the opportunity to present today. We have no disclosures. So as we just heard, pancreatic neuroendocrine tumors, or PNETs, are rare tumors. They represent about 1% to 2% of all pancreatic neoplasms and are believed to be increasing in incidence. Their behavior ranges from indolent tumors to aggressive metastatic disease, with a small subset of tumors being eligible for active surveillance while the rest will undergo surgery. Current guidelines do not incorporate genomic markers into this decision-making, and R0 surgical resection remains the standard of care for disease-free survival, as we just heard as well. Distant metastases, lymphatic invasion, neural invasion, and advanced histologic grade are all associated with decreased disease-free survival. So in terms of genetic background, about 5% all the way up to 17% are due to germline mutations associated with familial syndromes, while the remaining 95% are due to somatic mutations. Now, the individual prognostic significance of any of these somatic mutations is highly debated, and particularly their role in recurrence after R0 resection remains essentially unknown. In terms of mechanisms of tumorigenesis, the most frequently cited mutations are MEN1, DAX, ATRAX, and PTEN. Specifically for DAX and ATRAX, these are genes involved in chromatin remodeling, and when they undergo either ATRAX or DAX, when they undergo a silencing or inactivating mutation, that will lead to chromosomal instability and subsequent activation of alternative lengthening of telomeres and subsequently tumorigenesis. So for our study, we aim to identify genomic signatures of disease-specific mortality and recurrence after R0 resection, as well as any genomic mediators of aggressive clinical features. We reviewed all available PNET studies in cBioportal and retrospectively collected all genomic, clinical pathologic, demographic, and outcomes data. For those of you who aren't familiar, cBioportal is a publicly available database that features multiple published data sets of whole exome sequenced tumors, as serving as an interface to work with the Cancer Genome Atlas and the remaining studies. For our study, we analyzed non-synonymous mutations, structural variants, and clinical data. And specifically, any of the data available here was able to be viewed on both the individual patient level as well as for the population level, which can help aid in conducting meta-analyses. So again, for our study, we included all available PNETs initially, and then included just R0 resected tumors with available survival data before dividing them into two cohorts. The first being those who were disease-free at the time of last follow-up, obviously representing the disease-free cohort, and compared them to those who experienced a recurrence or a recurrence and disease-specific death, titled the recurrent cohort. So ultimately, we ended up with 70 R0 resected patients, 45 of which were disease-free at the time of last follow-up, and 25 of which experienced a recurrence. In terms of our demographic results, the cohorts were well matched with no significant differences for median age, sex, race, or median follow-up. However, for clinical pathologic results, the recurrent cohort exhibited a greater median tumor size, a higher incidence of vascular invasion, node-positive status, metastatic status, and moderately differentiated tumor grade. However, they did not differ in regard to perineural invasion, extrapancreatic spread, or the incidence of poorly differentiated tumors. In terms of tumor mutational burden, or TMB, the median TMB was significantly greater in the recurrent cohort. TMB has been proposed as a general marker of tumor immunogenicity, and specifically a standardized cutoff of greater than 8 to 10 mutations per megabase has been proposed as a kind of predictor of response to immunotherapy across multiple solid organ malignancies, specifically checkpoint inhibitors. And so as you can see, despite the significant value statistically, it's unlikely to be clinically significant, which is consistent with previous literature investigating the role of pembrolizumab in PNETs. Moving on to our genomic data, so we analyzed any gene with a prevalence of greater than 10% in the recurrent cohort and ended up with MEN1, DAX, ATRAX, and PTEN as expected, and found that only DAX was associated with the recurrent cohort. Next, we performed a univariate logistic regression, which revealed that metastatic status, node-positive status, increasing tumor size, vascular invasion, and DAX were all associated with recurrence or death from disease, while again, female sex and perineural invasion had no effect. However, likely owing to an underpowered DAX analysis, only metastatic status and vascular invasion were significant on multivariable logistic regression. So given DAX's association with recurrence on univariate analysis, we assessed its relationship with clinical features and found that it was associated with vascular invasion uniquely. We performed the same analysis for the remaining genes. So for MEN1, there were no significant associations. For ATRAX, there was an association with node-positive status. For PTEN, and finally for PTEN, there were no significant associations. So obviously this study has a number of limitations. It's retrospective data, and higher powered studies would be needed to elucidate the role of DAX independently as it pertains to R0 resection. And then further, our definition of surgery for curative intent. R0, as it was depicted in the database, we assumed that that meant that the patient was cleared of all disease. However, the primary source authors weren't explicit as to the extent of surgery for any individual patient. Further, the type of mutations we examined were limited to single nucleotide polymorphisms and structural variants, so the epigenetics and copy number alterations that are characteristic of other oncologic phenotypes, such as those seen in ACC, were not included. So in conclusion, on univariate analysis, DAX is significantly associated with recurrence after R0 resection. DAX is associated with the development of significant high-risk clinical features, specifically vascular invasion. And finally, vascular invasion and the presence of metastases are the highest correlated features in regard to recurrence after R0 resection. So obviously, for next steps, we would need prospective data to evaluate the candidacy of DAX as a biomarker for vascular invasion and any role it may have in guiding surveillance or surgery in the future. That's all. Thank you very much.
Questions?
Yes, hi, Xavier Koik in Chicago. Great paper. So a couple of questions and a couple of comments. So first of all, as a comment, we just recently found that actually DAX, ATRX, and MEN1, who are basically all involved in DNA repair, are essentially associated with improved progression-free survival after PRRT. This has nothing to do with this, but just as a general comment, I think that there's a lot of ways that we can look at mutations and how they can be helpful in a clinical situation. The second comment, or the second question, or the first question in this case, and then the second question is, number one, did you specifically look at those patients that were non-metastatic and had an R0 resection, and whether DAX was still significant there? Because the problem we're dealing with is obviously when you say R0 resection, it can mean a lot of things, and the bottom line usually is that even if you do an R0 resection in a metastatic patient, you know, these patients are going to recur, no matter what, most likely. And then the second question is, how is this changing our practice? So let's assume what you found is real, and DAX actually does predict a high chance of recurrence. What would you suggest we do differently than what we're doing now?
Sure.
Thank you, great paper.
Thank you very much. So in regard to the first question, I think as I mentioned in the presentation, unfortunately DAX was underpowered for that multivariate analysis, but specifically after removing the metastatic patients from that cohort, obviously that was no longer significant either. That said, I think what may have merit, at least as a hypothesis generating approach, is that obviously vascular invasion proved to be a strong marker, and DAX's association with that may be more promising. In terms of how this could affect the field in the future, I think, you know, at least at our institution, next generation sequencing is becoming more routine across a number of endocrine malignancies. And I think with a mutation that's present in up to 40% of these tumors, we'd have the opportunity, at least for specific testing, if it proves to be prognostically significant on future studies, to consistently test for that and potentially guide therapy after R0 resection. Thank you.
Jim Howe, Iowa City. Great study, really enjoyed listening to that. In Europe, they're using ATRX, immunohistochemistry, on EUS-guided biopsies in those troublesome 1 to 2 centimeter neuroendocrine tumors to try to decide whether they're more aggressive and they should do resection. I'm curious, I haven't really heard about DAX being used. Is there an immunohistochemistry test for that could be used similarly to ATRX?
Honestly, not to my knowledge. In the literature we saw for this paper, I haven't seen any routinely used immunohistochemistry for staining for any of these markers, specifically outside of whole exome sequencing. Thank you.
Hi, Naresh Nilabo, Bethesda, Maryland. I think I really enjoy your presentation, but I think your two cohorts are a little bit different between the recurrence and non-recurrent cohorts. You have tumors that are genomically altered because you have more TMB and bigger size and all that. That might be the reason that your DAX did not come up in multivariate analysis, because DAC is more epigenetic regulation and histone accessibility. Now, the question to you is the invasion versus the DAX mutant and DAX wild type comparison, did you adjust for other characteristics, sizes, and all other things?
So not specifically for the clinical features analysis, but thank you, it's a point well taken.
I'm sorry, we're going to have to move on. We're over time. Thank you very much,
Thank
Dr.
you.
Greenspan.
Our next paper is Recurrence and Treatment Trends of Pancreatic Neuroendocrine Tumors, an 18-year review presented by Dr. Amanda Bader for her colleagues at Penn.
Good morning. My name is Amanda Bader. I am a general surgery resident at the University of Pennsylvania. I want to thank the AAES for the privilege of the podium and the opportunity to present our work on pancreatic neuroendocrine tumors. We have no disclosures. As we've heard many times, pancreatic neuroendocrine tumors, or PNETs, are rare tumors, representing only 1% to 2% of pancreatic neoplasms. However, overall survival is excellent, and the mainstay of treatment is surgical resection for tumors 2 centimeters and above. Despite this, about 15% of patients with PNETs experience a recurrence after surgery. And while predictive risk factors for recurrence have been studied, treatment regimens are not as well defined. Similarly, trends in treatment for PNET recurrences have not been described in detail. Therefore, the aims of our study were to assess the incidence and patterns of recurrence of PNETs in a single institution experience, to evaluate the impact of recurrence on survival, and to describe the trends in treatment of recurrences over an 18-year period. This was a retrospective cohort study in a single academic institution. We utilized 2 separate databases. One of them was a prospectively collected internal pancreatectomy database, and the other was our institution's tumor registry, which is also prospectively collected for submission to the National Cancer Database. We included all patients with pathologic or histologic diagnosis of PNET or islet cell tumors who underwent surgical resection, and we excluded patients presenting with synchronous metastatic disease, high-grade tumors, or poorly differentiated tumors. We collected a number of covariables, which included preoperative diagnostics, pathologic characteristics, including tumor grade according to the World Health Organization 2017 classification system, and recurrence characteristics such as timing and treatment of recurrence. We looked at several outcomes. First was time to recurrence, which was calculated from date of initial surgery to date of recurrence. We defined recurrence as either biochemical or radiologic evidence of disease at least 6 months after initial surgical resection. We also looked at risk factors for recurrence using multivariable regression modeling and using a competing risk framework to produce sub-distribution hazards. We wanted to also look at therapeutic modalities for recurrence and trends in treatment. In terms of secondary outcomes, we looked at overall survival, which was calculated from date of surgery to date of death or last follow-up, and recurrence-free survival, which was calculated from date of surgery to date of recurrence or last follow-up, where recurrence was treated as a time-varying covariate. Overall, 284 patients in both databases had a primary pancreatic neuroendocrine tumor. However, of those, only 182 patients underwent upfront surgical resection for a well-differentiated G1 or G2 tumor. Of those 182 patients, 44 patients experienced a recurrence, and 39 of those patients were ultimately treated. Here's a quick snapshot of our cohort. You can see 51% of the cohort was male, the majority of patients identified as white race, and the median age was 60 years. The most common initial surgery type was distal pancreatectomy, and both tumor size and nodal positivity were significantly different in patients who recurred versus those who didn't recur. Our median time to recurrence was 57 months, which is just under 5 years, and our median follow-up time was 99 months with a accrued recurrence rate of 24%. When looking at overall survival, the 5-year survival in the full cohort was 90.6%, and when looking at overall survival in just the recurrence cohort, this dropped to 71.2%. Interestingly, the risk of death was not significantly higher in patients with recurrence compared to those without a recurrence. When looking at recurrence-free survival, we found that the 5-year survival was 85.8%, which is on par with previous literature. For a univariable model, we found both tumor size and nodal positivity were significantly associated with risk of recurrence. However, on multivariable analysis, we found only nodal positivity was significantly associated with recurrence, which is depicted here in this figure. As you can see, if a patient had 1 or more positive lymph nodes, they were 4 times more likely to recur than if they had no positive lymph nodes. In terms of the recurrence, most, 77%, recurred in the liver, and most were initially diagnosed radiologically. In terms of treatments, most patients received 2 or more treatments for their recurrence, and the most common initial treatment of recurrence was somatostatin analog. Of the 44 patients who recurred, 12 patients received peptide receptor radionuclide therapy, or PRRT. We also saw that many patients received sandostatin at some point during the course of their recurrence treatment. In terms of liver-directed embolization, we saw that many patients received transarterial radioembolization, or TARE, transarterial chemoembolization, or TACE, or a combination of both. When looking at trends, we note that for TACE and TARE, they're being increasingly utilized after the year 2010 and 2012. Similarly, there was an increase in the utilization of PRRT for treatment of recurrence after its approval in the United States in 2018. When looking at embolization by initial surgery type, we see that in patients who initially had a Whipple, they were more likely to receive a TARE as compared to a TACE. But both Whipple patients and distal pancreatectomy patients were equally likely to receive an embolization in general. This study is not without limitations. Given this is a single institution study, we are limited by small sample size, so we have a more heterogeneous cohort, and we are limited in the subgroup analyses that we are able to perform. This is also a retrospective study, and so the study might be plagued by some misclassification bias of our covariables. Given this study spanned 20 years, we know that imaging detection and therapy has improved over time, which could also introduce a degree of bias. And given we only looked at patients who had upfront surgical resection, this limits the generalizability of these results to only this subpopulation. However, within these limitations, we saw that 24% of patients with well-differentiated G1 or G2 PNETs recurred. Nodal metastasis is an important risk factor for recurrence. We also saw that recurrence was not significantly associated with survival, which is more likely due to our small sample size and the fact that we are possibly underpowered, but also could be due to the fact that these treatments are in fact working. We did see that newer therapies are being increasingly utilized in the past couple of years, and perhaps as we more aggressively treat these recurrences, there's actually an impact on survival for patients. Thank you so much for your attention, and I invite any questions.
Jim Howe, Iowa City. That was a great talk and a great presentation from the group at University of Pennsylvania. It wasn't surprising that nodal positivity was associated with higher recurrence rate. But I was curious about two things. One is the non-liver recurrences. You had 7 pancreatic recurrences, and I was curious how many patients had VHL or MEN1. And then getting to the small bowel recurrences, I'm not really sure if those are recurrence or second primary. So that was the first question. The second one was why there's no difference in survival for people with recurrence. I don't think our therapies are that good, but maybe at the University of Pennsylvania, where you do a lot of great embolizations, it is. So I'd like to hear your comments on that.
Thank you so much for that question. So for your first question, when we looked at the patients who had the pancreatic recurrence, most patients recurred locally. And when I further broke it down, probably the majority, I think there was 7 and at least 6 had recurred locally. There was one patient who had initially had a Whipple and recurred distally, and that patient had an MEN variant, but the rest of the patients who recurred in the pancreas did not have any genetic variants. As to your second question, it's a great question. I truly think that our study was probably underpowered. When I did some power, calculations, I found that we would probably had to have had a cohort of at least 300 people with about 100 recurrences to really see a difference in survival. And there have been some fabulous multi-institutional studies that have showed that there is an increase of risk of death with recurrence. And so I think that our study was probably underpowered.
Thank you.
Salem Neurodean, Washington, D.C. I really enjoyed your talk. One thing that you didn't share with us is how complete were the resections? Were there R0, R1, R2? I'm specifically interested in the R1 resections. There's a lot of data for pancreatic adenocarcinoma that radiation is helpful, but we don't really know for pancreatic neuroendocrine tumors. So that'd be interesting to also see if you can go back and look at, but I'm interested if you examine that as well.
Yeah, we did not collect those data, but I agree that would be very interesting to look at.
Xavier Cartman, Chicago. So 2 comments, 1 question. You only operated on 25% of your recurrences in the liver. Any reason for that? I would actually recommend that at least if they are, debulkable recurrences, we should probably reoperate on them before we give them any more systemic therapy, except of course for like long-acting octreotide. We have found, at least in our experience, that this actually really prolongs the next step of treatment. So you give them octreotide, you watch them, make sure the biology is okay for 3 to 6 months. You do the operation, and then you take them off the octreotide, and then you just watch, and it gains you many years until you need to go to the next treatment cycle. The other comment I have to say is. Mike Solon at the University of Pennsylvania and I very often debate on that. You've used a lot of TARE in your patients. And this is a thing that they use at UPenn a lot. I would just caution the surgeons here in the audience when they send them to IR to not necessarily advocate for TARE. I just don't think we have the data out there. There's TARE significantly better than Blan-Embo. There is, however, some data out there suggesting that the cumulative radiotoxicity of TARE and perhaps PRT is going to damage these livers long term. So these patients live a long time, you just showed it to us. We just got to be cautious about what we're using for liver-directed therapy. And here's my question. Did you look at DAX?
I can answer that one easily. No, we did not look at DAX.
Maybe you should, and maybe you should collaborate with Tom and see if that's right, because he got a great cohort here to look exactly at Tom's question.
Yeah. As to your first question, though, about the decision-making in the surgery, it's hard to tell because we didn't collect those data. We didn't look at how much volume of tumor they had in their liver. I know in general we have a multidisciplinary group that looks at everyone with recurrence. It's the same group of people, and they recommend treatments based on that. And from what I understand from conversations with some of my attendings, based on the amount of tumor recurrence that they have in the liver is when they'll offer surgery. But unfortunately, we didn't collect those data for the purposes of this project.
And then one last super question, I missed it, but did you give me your time to recurrence in those patients that recurred?
The median time to recurrence was 57 months.
57?
Yeah.
Okay, great, thanks.
Thank you, Dr. Bader, for a fantastic presentation. I'd like to now call Joe Tobias up to the podium to present his paper entitled Surgery Enhances the Effectiveness of PRRT in Metastatic Gastroenteropancreatic Neuroendocrine Tumors, on behalf of his colleagues at the University of Chicago and the University of Tennessee Health Science Center.
Good morning, and thank you very much for the opportunity to present our work. we have no disclosures. Metastatic, well-differentiated neuroendocrine tumors have 5-year overall survival rates of less than 50%. According to current NCCN guidelines, patients with metastatic NETs should be treated with somatostatin analogs as first-line therapy. But what to use as second-line therapy, including peptide receptor radionuclide therapy, or PRRT, and liver-directed therapy, remains controversial. Resection of the primary tumor and debulking of liver metastases, while not curative, does improve symptoms and prolong survival, but the optimal timing of surgery and the treatment sequence remains unknown as well. Peptide receptor radionuclide therapy, or PRRT, targets somatostatin receptor-positive neuroendocrine tumors with lutetium-177 bound to a somatostatin analog. PRRT delivers targeted radiation to tumor cells in a manner analogous to radioactive iodine in the treatment of differentiated thyroid cancers. In the landmark 2017 NETTER-1 trial, PRRT resulted in longer progression-free survival in grade 1 and 2 metastatic small bowel neuroendocrine tumors compared to long-acting octreotide alone. And in a primary analysis of the NETTER-2 trial, just released in January of this year, PRRT also resulted in longer progression-free survival in grades 2 and 3 metastatic gastroenteropancreatic neuroendocrine tumors, or so-called GEP-NETs. Notwithstanding these successes, objective response rates to PRRT remain low, and most patients do experience disease progression within 12 to 36 months after PRRT. Interestingly, a sub-analysis of the NETTER-1 trial showed that patients with liver lesions larger than 3 centimeters had shorter survival after PRRT. With this in mind, since surgery reduces tumor volume, we hypothesized that primary tumor section and liver debulking prior to PRRT might improve the effectiveness of the therapy. We performed a single-center retrospective study of patients with metastatic GEP-NETs from 2018 to 2023. Primary outcome was progression-free survival in months, comparing patients who underwent surgery with primary tumor section and/or liver debulking to patients who never had any surgery. Secondary outcomes included variables affecting progression-free survival. 56 patients had primary tumor section and/or liver debulking, while 33 never had any surgery. Of the 56 patients who had surgery before PRRT, 24 or 43% underwent primary tumor resection only. 32 patients, or 57%, underwent liver debulking concurrently with or after their primary tumor resection, and only 1 patient had debulking surgery without any primary tumor removal. Between 2018 and 2023, 137 patients at our institution were treated with at least 1 cycle of PRRT. 89 patients were ultimately included in our analysis. Median age was 63 years. The most common primary tumor site was the small bowel, followed by the pancreas. With regard to variables affecting severity of disease, the majority of patients had grade 1 or 2 primary tumors. All patients had liver metastases, but 73% also had known extrahepatic disease, most commonly nodal and skeletal metastases. Median follow-up in the cohort was 40 months. Importantly, there were no significant differences between the 2 groups in terms of age at the time of PRRT, tumor grade, primary tumor site, rates of extrahepatic disease, as well as rates of having received systemic therapy and/or liver-directed therapy. There were also no differences in the number of PRRT cycles completed. Median time from the most recent surgery to PRRT was 32 months. This is a case of a 60-year-old patient with a small bowel neuroendocrine tumor metastatic to the liver who underwent liver debulking prior to PRRT. Panel A shows the preoperative MRI depicting extensive hepatic metastases and the corresponding dotatate PET scan with a tumor volume of 919 cubic milliliters. Panel B shows the postoperative MRI with debulking changes in the corresponding PET with a tumor volume reduction to 157 cubic milliliters. Kaplan-Meier estimations of progression-free survival after PRRT showed that median progression-free survival was 15.6 months in the no surgery group, compared to 18.1 months in the primary tumor resection only group. This difference did not achieve statistical significance. Importantly, however, PFS was almost 11 months longer in the debulking group compared to the no surgery group, with a median progression-free survival of 26.2 months, and this result did achieve significance. Tumor volumetric data were calculated from PET scans prior to the first cycle of PRT and were available for 74 out of our 89 patients. We found the tumor volume was lowest in patients who underwent liver debulking at 146 cubic milliliters, and highest in patients who had no surgery at all at 626 cubic milliliters. Furthermore, a tumor volume threshold of 138 cubic milliliters minimized the ROC curve of progression-free survival after PRT. Based on this result, a tumor volume less than 138 cubic milliliters was associated with a median progression-free survival of 38.1 months after PRT, while patients with tumor volumes greater than 138 had a median progression-free survival of 17.8 months after PRT. On univariable analysis with Cox proportional hazards modeling, there was a significant difference in PFS after any surgery. Additionally, tumor volume less than 138 cubic milliliters was also significantly associated with longer survival. Notably, however, neither surgery nor tumor volume retained significance in the multivariable model, while higher grade and systemic chemotherapy did remain significantly associated with shorter progression-free survival in the multivariable analysis. In conclusion, surgery prior to PRT with primary tumor removal and debulking of liver metastases was associated in this retrospective study with significantly longer progression-free survival after PRT. PRT was seen to increase, PFS, was seen to increase based on the extent of surgery, with a greater difference after liver debulking compared to primary tumor resection only. And tumor volumes less than 138 cubic millimeters correlated with an improved progression-free survival of 38.1 months. In parallel, the lowest tumor volumes were seen after liver debulking. When trying to understand why surgery might improve progression-free survival after PRT, we suspect that surgery, by decreasing tumor volume, may allow for more radioligand to distribute within the tumor burden. Although we can't conclude yet that a causative rather than purely associative relationship between surgery and progression-free survival after PRT does exist, our group believes that these findings begin to fortify the concept of using surgical debulking to improve the effectiveness of PRT after systemic therapy. Thank you very much for your time. I'll take any questions.
Yeah, hi, it's Mike Demur. Thank you for elegant series and nicely presented. My question is that related to PFS as an endpoint. You know, the FDA is souring on that, and what we really want to see is overall survival, and I gather, I don't know if you have data, but more specifically, did you have any data about how many of those patients had documented progression before you did surgery? And then what about just, you know, keeping them on SSA after the debulking surgery and then have progression before PRT? Did you have any data before that? Because PRT is approved for people who progress on SSA.
So thank you very much for your question. Just to clarify, all patients were on somatostatin analogs, progressed on somatostatin analogs, and then subsequently received PRT in this study. It's a well-taken point. And also all patients had had progression of disease prior to, well, the vast majority had progression of disease prior to surgery as well. No overall survival data yet.
Paxton Dixon, Memphis, Tennessee. Thank you for the outstanding presentation and enjoyed it. My first question was actually the same one that Dr. Demur had asked, but the second is, in patients who may not be candidates for aggressive surgical debulking of the liver, but have progressed, have liver-dominant disease and have progressed on somatostatin analog therapy, what about the role for bland embolization as a debulking mechanism to try to kick PRT down the line, and what your group's experiences or thoughts on that would be curious to that.
It's a very good question. There's no data yet on the efficacy of liver-directed therapy in terms of reducing tumor volume, although clinically we see that it's very effective. I think that one of the things I didn't mention in my talk is that, there's a selection bias, obviously, in a retrospective study. And so we did look at the 33 patients who didn't have surgery. And the truth is that 20 out of 33 were likely operative candidates. So, the question of who is debulkable and who can actually have surgery is highly dependent on practice patterns.
I want to commend the group at University of Chicago for doing this study, and it's been an area of great interest, I think, for decades since PRT came into the fold. I think it was in 2005 that Queckenboom at Erasmus suggested that people with lower tumor volumes would have a better response to PRT. There have been a few other studies, Ezedin and Campana wrote similar things, and then Kammerer in 2021 presented data showing primary tumor resection with PRT versus PRT alone, showed not only a PFS benefit, but also a doubling of OS. And whether that's real or selection bias is really hard to sort out. But I wanted you to just expand a little bit on explaining what you think the mechanism would be by cytoreduction. I think you hinted at it. And then the second thing I wanted to ask about, I've become aware now that with PET scans, it's not that hard to calculate tumor volume. So maybe you could expand on that as well.
Thank you very much, Dr. Howe. In terms of the mechanism, what we suspect is that you can make an analogy to radioactive iodine in the treatment of differentiated thyroid cancer, that the radioligand has less tumor to ablate in the setting of lower tumor volume, accomplished through surgery or potentially through liver-directed therapy. And it's possible that that has to do with penetration of the radioligand into deeper, larger tumors, or it just has to do with more radioisotope per capita of tumor. We are studying that at the University of Chicago in biological models. And then in terms of calculating tumor volume data, there's a program called the MIM Encore workstation that our nuclear medicine colleagues use. It's semi-qualitative and semi-quantitative, and based on the SUV and receptor density of tumors on dotatate PET scans, the program is able to generate tumor volume data, and then a nuclear medicine physician actually looks at the scans and ensures that the algorithm has accurately captured the tumors. So, draws borders around those light bulbs on the PET scan.
We have time for one quick question.
Tim Beck, Cleveland, Ohio. Thank you so much for this great talk. One question I had, is there any difference or indication that there's a difference in terms of quality of life after surgery or no surgery? Thank you.
Thank you for that question. One of the sort of great benefits of surgery is that we see, patients with carcinoid syndrome who have serotonin levels in the thousands after surgery and are flushing and symptomatic. After surgery, their serotonin normalizes and their symptoms vastly improve.
Great, thank you. Our next paper, we'd like to invite Dr. Ellen Novis up for oncogenic mutations in TP53 and PI3 kinase ATKT pathways are independent predictors of survival in advanced thyroid cancer. Analysis from the Molecular Screening and Therapeutics Program.
Thank you very much to the organizing committee for this invitation. It's a privilege to present our work on behalf of the team in Sydney, Australia. My name's Ilan Novis, and I'm a surgical oncology fellow in Sydney, and I think my supervisor, Professor Anthony Glover, who's in the audience today. We have no disclosures. So our understanding of the molecular biology and genetics of thyroid cancer has undergone significant change in the past decade, with thanks to the development of the Cancer Genome Atlas and next-generation sequencing. We know that the initiation of thyroid cancer involves alterations in the MAP kinase pathway due to driver mutations in either BRAF, RAS, and a subset of thyroid cancers have fusions involving RET, PTC, and NTRK. Several genetic alterations have been shown to be more prevalent in advanced thyroid cancers, including poorly differentiated and anaplastic thyroid cancers, such as TP53, TERT, and PI3 kinase pathway mutations. However, the clinical significance of some of these mutations remains uncertain, and currently there is little data to correlate these genetic alterations with long-term survival outcomes. This knowledge may significantly modify care decisions and allow a more targeted approach to treatment. To better understand the relationship between survival outcomes and the presence of specific gene alterations in the thyroid cancer pathway, we analysed the genomic profile of tissue specimens from patients with advanced treatment-refractory thyroid cancers using the Molecular Screening and Therapeutics Program in Australia. This national program recruited patients with advanced solid tumours refractory to standard therapies to provide comprehensive genomic profiling and potentially identify molecular targets for treatment. Patients aged greater than 18 years of age with treatment-refractory, locally advanced or metastatic cancers, either during or after their last line of effective therapy, were screened using comprehensive genomic profiling of an archived tumour specimen. This genomic profiling results were reviewed by a molecular tumour board and a matched actionable genomic finding relevant to a clinical trial of a targeted therapy, which was the main aim of this program. However, we were able to capture the data from these patients and to correlate their genetic profiles with their survival outcomes. And the primary outcome of our study was overall survival, which was measured from the time of diagnosis of metastatic disease. In the nearly 4-year period in which data was collected, close to 5,000 patients were recruited to the program, of which 44 had a diagnosis of thyroid cancer. 4 of these patients had medullary thyroid cancer, while 17 had differentiated thyroid cancers, 13 poorly differentiated, and 10 anaplastic thyroid cancers. The majority of patients presented with a thyroid or neck mass. 60% had received prior tyrosine kinase inhibitors, 69% prior radiotherapy, and some had previous chemotherapy or immunotherapy. When analysing the overall survival in this cohort, patients with follicular-derived cancers had a median survival from time of diagnosis of metastatic disease of 81 months, with a 5-year survival of 61%. The median survival from time of thyroid cancer diagnosis was 93 months, with a 5-year survival of 68%. Not unsurprisingly, when stratified into histological subtypes, the poorly differentiated and anaplastic thyroid cancers had worse survival outcomes. The sequencing of the 40 follicular-derived thyroid cancers revealed a median of 2 variants per tumour with a range of 0 to 6. The tissue was obtained from the primary thyroid cancer in 63% of patients, with the remaining patients having sequencing from metastatic tissue, 9 of which were from lymph nodes and the remaining from other distant metastatic sites. Sequencing of the primary cancer compared with metastatic tissue did not show any significant difference in the number of variants detected, both having a median of 2 variants. But the number of variants detected in the anaplastic thyroid cancer and poorly differentiated thyroid cancers was slightly higher with a median of 3 variants detected. The range of variants seen described here, with P53 mutations being the most common, followed by BRAF, E600E, NRAS, and TERT promoter mutations. Mutations in the RTK-RAS pathway were present in 55% of patients, the P53 pathway in 42% of patients, and the cell cycle pathway in 17%, with PI3 kinase pathway mutations being present in 22% of our thyroid cancer patients. The presence of a P53 mutation was associated with a reduced overall survival compared with samples without P53 mutations, with a hazard ratio of 5. And this was also the case in the presence of mutations in the PI3 kinase pathway compared to those without mutations in this pathway, with a hazard ratio of 10. Amongst patients with alterations in both P53 or PI3 kinase pathways, a significantly worse overall survival was seen compared to no mutations in these pathways, with a hazard ratio of 4.7. And when we excluded the anaplastic thyroid cancers, this difference remained significant, with a 5-year survival of 55% compared to 85% in those without mutations in these pathways. And interestingly, our analysis did not demonstrate an association between overall survival and TERT promoter mutations in this cohort. An examination of associated clinical features showed that patients with P53 and or PI3 kinase mutations were likely to have a diagnosis of anaplastic thyroid cancer and subsequently were more likely to receive chemotherapy, but otherwise there was no other significant association between age, sex, use of tyrosine kinase inhibitors, or the presence of other mutations. The poorly differentiated and anaplastic histotypes, as well as the presence of P53 and PI3 kinase pathway alterations were independently associated with overall survival, and the presence of P53 and/or a PI3 kinase pathway mutation had a 4.7-fold increased risk of death compared with tumours not harbouring mutations in these pathways, with a median overall survival reduced from 81 months in patients without mutations to 19 months in those with mutations in these pathways. So in conclusion, within our Australian National Precision Oncology Program, P53 and PI3 kinase pathway alterations were an independent predictor of overall survival amongst a cohort of advanced follicular-derived thyroid cancers, and these results suggest a role for comprehensive genomic profiling in informing prognosis, risk stratification, and identification of therapeutic targets in our patient population. I thank you for your time.
This paper is open for discussion. Dr. Nillabo.
Hi, Naresh Nillabo, NCI, Bethesda, Maryland. I have two questions for you. One is very simple. Could you define what is treatment refractory is? I'm assuming it's RAI, but is TKI a part of that too?
Thank you for the question. So treatment refractory differed. Obviously, we had quite a heterogeneous patient population. It depended on the type of tumour the patient had, how they presented, and how they tolerate each procedure, so each treatment option. And so it was determined by the treating physician from whichever institution they were referred from. But in general, it was radioactive iodine refractory disease or disease that had progressed on TKI, previous TKI treatment.
So it's a combination of them?
That's correct. And again, it depends on the patient and whether they had, for example, anaplastic thyroid cancer compared to a differentiated thyroid cancer.
So that leads me to the second question. When you compare the wild type and the mutant cohort, like say P53 wild type in the cohort, that you saw the difference, so even with PI3 kinase AKT pathway mutations. So the wild type side, are you referring those with BRAF mutation as well? In other words, some of those may be the anaplastic with BRAF mutant that got treated with trametinib and dabrafenib. Thus, the survival benefit or difference would be from those effective treatments.
Thank you. So the vast majority, almost all of our patients had their comprehensive genomic profiling performed on their initial primary tumour biopsy. So it was a retrospective molecular study of these tissue samples prior to receiving tyrosine kinase inhibitors or any other treatments. And so we presume that their genomic profiles were unaltered at that time, rather than studying them after receiving gene-altering therapies. I hope I answered the question.
David Velasquez from Mexico City. Thank you very much. I really enjoyed your paper. It was fantastic. I have two questions. The first is, do you think really P53 is a driver mutation? Because it's mostly related to advanced disease, mainly genomic instability. What do you think about that? And the second thing is, do you study about this, how to say, the differentiation genes are related to this refractory to the iodine?
Thank you for your question. I agree. I don't begin to think that I'm an expert in this field, but I believe that a P53 mutation is more of a downstream mutation and more of a marker of more advanced disease, which I think why it was so prevalent in our patient population. In a majority of these patients, I think the driving mutations remain either BRAF or RAS mutations, but certainly P53 and PI3 kinase play a significant role in the more downstream, more advanced mutational profile. And sorry, your second question?
The differentiated genes, or genes related to this differentiation.
I'm not sure. I'm not sure I can comment on that. I'm sorry.
That's okay.
Thank you for your question.
And then one last quick question. If I heard you right, it looks like your metastases were not very different from your primary tumors, which flies in the face of some data that says that there's changes in some of the genomic patterns in these metastases. Can you speculate a little bit about that? Is just because it's remained well differentiated, or do you have any kind of hypothesis to explain that?
I suspect it comes down to our patient cohort again. So these patients are being referred to us with rare, very advanced forms of thyroid cancer, and so potentially they developed from specific gene mutations that were present initially, rather than accumulating a number of genetic mutations. It's hard to know without comparing our data to a baseline population of thyroid cancer patients. But I take the point. Thank you.
I'd like to thank all the authors for this great session. Thank you.
Please don't go anywhere. We're going to move into our next session directly.
So thank you to the moderators and the presenters. And as a reminder, we were going to have our paper 12 that we did not present yesterday and presented on this session. I would like to invite our moderators, Dr. Grubbs and Dr. David Velasquez, to come to the stage. And we'll